All right, let's get started. So good afternoon again, everybody. It might be a little bit early in the afternoon for others. I'm in Boston, Massachusetts. My name is Chioma Nnaji. I'm the director at the Multicultural AIDS Coalition, which is a grassroots HIV and sexual health organization, again, in Boston, Massachusetts. I am excited to introduce this webinar, this couch conversation, I should say, to you all. Is brought to you by United We Rise. And I'll give you a little overview about United We Rise, and then we will get into our panelists, our moderators and our panelists. So today, our conversation is a part of a three-part couch conversation on EHE and every Black body. And today, our question that we're going to be having some dialogue and critical thinking around is, what is the legacy of EHE for every Black body living with HIV? Again, this will powered by United We Rise, and United We Rise is divided into, we work as work groups. And the work group that put this together is the Change the Narrative work group. And you see all of the members listed there. We are partly funded by Gilead and ViiV. So please go ahead in the chat, type your name, your organization, if that applies, and the city that you're at. I know that we have folks here from across the US and folks who are doing amazing work, whether it's in HIV, whether it's in reproductive health, all the ways in which HIV intersects with other topics in communities. So please go ahead and take some time to put your name, organization, and city in the chat. Before we get into our couch conversation, I want to take a little time to introduce you to United We Rise. United We Rise started about 4 years ago, really with the idea that there's something different that needs to be done in order to fully address the HIV/AIDS epidemic in our communities, Black communities. This initiative is Black-led, and we really hold dear it being intersectional. So we think about making sure that we have all communities that are impacted by HIV, as well as thinking about what are all the other issues and topics that we need to be talking about if we really want to address this in our community. Our mission is to reimagine the way that HIV is addressed and understood, even understood within the field. And it's not only about us addressing HIV, but also ways in which we're uplifting health and liberation for all Black people. So I'm going to share a video to give you a little bit more content. You might recognize the folks that are in this video, but this video will showcase the individuals who are the founders of United We Rise. We started off with a 30-member planning committee. We still have a planning committee that evolves over time, but here you'll get the essence of the work that United We Rise, how it started and how it continues to evolve.
In 1997, I was diagnosed with HIV. It wasn't a big surprise. I knew that I had risk factors. I'm a recovering injection drug user, so I knew, even during that time when I was using drug, that there was some risk in doing that, and I shared needles, and so when I got ill and became sick, it wasn't a big surprise when the doctor suggested I take an HIV test, and it came back positive.
I was born positive. So tomorrow, actually, December 7th, I will be 33 years old. For me, that's something that I didn't even think would happen. A lot of us who were born HIV positive didn't even think that past our 5th birthday, past our 9th birthday, that we would even still be in existence. So for me, imperative that people understand and see that there are people who are still living with HIV who were born with it, because we're kind of the forgotten ones. People don't really hear about us.
I'm a Black woman fighting this struggle in the Muslim community. Doing this since 2008 when I was in college, started off in college. I met a friend who became positive, 19 years old. It really affected me. I realized I was ignorant about HIV and AIDS and nothing about it. So I went to my college campus, started an AIDS Awareness Week, and then I went to a hospital to work there part-time and met a Muslim living with AIDS. And he was he had a lot of hurt, a lot of pain, and he told me he didn't feel welcome in his own community.
Brought into HIV work because I'm a Black gay man of a certain age who was living in New York City at the time of the outbreak in 1981. The original cases were people who I hung out with, who I knew. We thought we were in a short-term situation, a crisis, but short-term, it's certainly something would come along to resolve the issue, and it didn't.
We were confused, it didn't have a name, it was GRID, they changed to a number, and then we came to AIDS. So it's been a fight for me for a really long time, and it's important to me that my village is not destroyed by it.
The Black community was being impacted not just by HIV, but by substance use and mental health. And I couldn't figure out a better way to spend my energy, but to begin to figure out how do we create healthy communities. I knew we weren't broken. I knew we weren't bankrupt. I knew that we had talents in our community, and I wanted to be a part of the solution and not part of the problem.
HIV is a disease, but because of the conditions that facilitate and support the disease transmission acquisition, particularly in our communities, to me it's a human rights issue. If housing instability remains an issue, if income inequality remains an issue, if negative experiences engaging healthcare professionals remains an issue, if stigma, bias, and discrimination continue to permeate in our communities, those issues will exacerbate whatever the disease is.
One thing I think is important that folks should know about an epidemic, that it requires unconditional love. And through love, we have access to patience. Through love, we have access to coming together, right? Unconditional love that gives us access to intimacy. Into me, I see you, right? So if I'm seeing you as another individual, I'm clear that it is my duty to love you as I'm loving myself. And so what is it that you need, sibling, that I can give you?
Everyone is impacted by this issue. And if we don't make some changes, if we don't open our arms to everyone and say, let's work together, we're not going to see the changes that we need to see.
We have been in the HIV epidemic for about 35 years, 37 years, and we find ourselves in a place where we're making advances in many populations and many communities, but the Black community is still bearing the brunt of the epidemic, and particularly certain populations like Black gay men and Black women have the highest proportion among women as well. And so we need to figure out a way to stop that, frankly. And the only way we're going to do that is for us to come together, to convene, and to talk about why it is that we aren't making some of the same advances as other folks. What are the systemic problems? What are the internal problems? How are we communicating with each other? How do we use our history and our love for ourselves, for Black people, to build the movement that can get us beyond this epidemic?
We all need to come and realize what is the commonality of all of us coming together, so that way we can combat this virus, we can get past this epidemic. And I think right now that as a unit, we can do that because we have everybody in the room right now. So that's the importance. I think that's what we can do.
And we often forget the grassroots efforts at the community level, and there are folks in our communities that are doing really good work that we could potentially learn a thing or two from that will get us closer to ending the epidemic.
We actually have to all roll up our sleeves and do the work.
I think if we come together and we learn from our past mistakes, we learn from our shortcomings where we've started efforts to end the epidemic and we've talked about what needs to be done, but we haven't actually implemented any change, I think we'll have success.
Our goal is to reach a day where there's not one person who dies of HIV or who is diagnosed with HIV, because it doesn't exist. And that's what our work has to be so clearly about. Ending the epidemic is just one phase in that.
I feel like we need to be clear about being unapologetic about our survival and the fact that we matter. We deserve to be here, our lives matter, and proving that is more than a document or a grant or meeting a deliverable. It's actually standing in the face of people and saying that we are here and we're not going anywhere.
So I have to say I got a little emotional. I didn't expect I was gonna have that reaction. Many of you all might have recognized a fallen warrior that in that video, Dr. Stefan Wallace. And so I want to lift his name up and also lift up Miss Barbara Joseph, who was also a part of United We Rise founding community, and then also lift up our most recent fallen warrior, Haidia, who passed away a couple of days ago. So let's just take a moment of silence for those three individuals. Thank you. I find peace in knowing that all three of them are on the other sides fighting the fight for us too, right? As ancestors. So please, in that video, you saw the energy, the passion, and really how people are thinking more critically about what we need to do from a lens of liberation, a lens of togetherness and community. And really addressing those structures that continue to make our communities vulnerable. So stay in contact with United We Rise. You see the information on Twitter, Facebook, and IG. Now I'm going to pass it over to our amazing moderators, and they will introduce our panelists. We have Mike Elizabeth. Mike Elizabeth works at Equity Federation, and Raniyah Copeland, who is at Equity and Impact Solutions. I will hand it over to you all.
Family, it's so good to see everybody and to be in space together. And that video this week for me has felt heavy. I feel super grateful to continue to be able to do this work. And I feel like the load is heavier in a way that feels empowering, right? Folks that we've been doing work with for decades and decades, shoulder to shoulder, when they kind of transition over to being ancestors. I think somebody says it's sometimes harder on us than it is on them because they're in a place of peace. But what we all do this work for and fight for is so that Black folks, Black bodies get to live long and healthy lives. And for me, it always feels a bit emotional, and it's hard when these amazing folks we don't get to have that. But their legacy continues. It's in this work, and I can't think of anything better than to be able to share space with y'all and have these conversations. And we're talking about legacy today, and we're talking about, what is the legacy of ending the HIV epidemic in Black communities. So excited to be with y'all for the next hour and some change and have conversation, and of course, being able to share space and co-facilitate with Mike.
Thank you so much for that, Raniyah. And yes, +1 to all of that. That was definitely heavy. But I think this conversation that we're about to have today is never more timely than now, especially after that video, right? I mean, how like, we talk about community a lot, but for me, I'm even now asking myself, how does the EHE work for the Black workforce in this space, right? Because many of us don't get to live as long as our white counterpart. And so without further ado, last week we did a deep dive into what the Ending the HIV Epidemic initiative is in the United States. Just as a brief reminder, we know the goals of the EHE is to reduce new HIV transmissions by 75% by 2025 and 90% by 2030. We know that EHE focuses on diverting resources in over 57 jurisdictions and local areas, including rural states like Oklahoma. I'm not going to go into the whole overview again. I feel like most of us here are already very aware of the Ending the HIV Epidemic initiative. However, just in case so we all can be on the same page, I am going to drop the slides that we used last week into the chat, and in case you want to review them on your own time. Outside of that, I would love to get straight into this conversation. We have some very, very exciting experts and panels here today. I know they're going to take us to church, but also help heal and empower some of our feelings right now that we're experiencing.
So let us kind of introduce one by one. The first person I want to bring into our Zoom space is Malcolm Reid. Malcolm from Thrive SS, do you mind giving us a quick introduction of yourself and what you're bringing here today?
Yeah, hi everybody. I'm Malcolm Reid, he, him, his. I am the Director of Policy and Advocacy for Thrive SS. Thrive stands for Transforming HIV Resentments into Victories Everlasting. And ESS stands for Support Services. Thrive was founded by 3 Black, same gender loving men living with HIV who were working in the public health service and saw the disparities and said, we got to do something about it. So shout out to Larry Scott Walker, Dwayne Bridges, and Daniel Griffin. I also represent Thrive on the USPL HIV caucus and serve as the Policy Action Committee Chair, and also the HIV and Aging Policy and Action Committee, Coalition, I'm sorry. And I work on the policy work group for the UWR. And so in Atlanta, which is one of the EHE jurisdictions, the Atlanta EMA, which is a 20 county metropolitan area and a very large Black population. You know, we're here trying to do the work, noticing that while the metrics are going down slightly, the stigma is still there, the misinformation is still out there, and you know, we still see people, young people, old people coming into our center newly diagnosed. So the fight is on.
Awesome. Very happy to have you and all that expertise and brilliance here.
Thank you. I'm glad to be here. Excited to be here. Wish I didn't have to be here. Let me just say that.
Next up, how about we bring Kayla down, also in the Georgia area. Kayla, introduce yourself, please.
Hello, everybody. My name is Kayla Quigley. I'm very honored to be in this space with everybody today. I don't really associate with one organization in particular, but I have been doing advocacy for about 10 years now, something like that. I'm a person with lived experience. I was born positive, so in this space, I intend to take up space for those who are born positive, as well as just people in general living with HIV, and hoping that we can all have some constructive conversation today. So thank you for being here with us.
Thank you for that. I think we're going to pull down Jahlove.
Hello, everybody. Super excited to be engaging in this important conversation and on the panel. My name is Jahlove Serrano, born and raised in the Bronx. I currently reside in Staten Island. I'm a person with HIV for 22 years, soon to be 23. And in a nutshell, I've infused my love of HIV and AIDS advocacy with my entertainment platform. I'm affiliated with so many organizations and platforms, but today I'm coming to you as a community person living with HIV. And my expertise on this conversation was that I was invited to the White House to give recommendation on the National HIV and AIDS Strategy Plan before we had one on negative and positive youth back in 2009, and I've been continuing this work. And so it's unfortunate that we still having these conversations, but I'm ready to get into all of it. So that's just a little bit about me.
Come on, Jahlove. Thank you so much.
And then I believe we have Teresa, yes.
Hi, everyone. My name is Teresa Otieno. Originally from Kenya. Kenya is in Africa. I'm based in Washington State, that is Seattle. I have been working in this field for 15 years now and more. Currently, I work for the Center for Multicultural Health. It's a community-based organization here in Seattle, and mainly working with people living with HIV to provide case management, psychosocial support, but I also coordinate our HIV prevention programs, like providing HIV testing, PrEP navigation, education. We are funded through EHE as well to provide services, provide testing services, stigma reduction, and education in the community. But most importantly, also, I do represent the African Sisterhood Empowerment Program. This is a network of women from Africa who are living with HIV, and we do similar things like coming together, supporting each other, educating each other, learning and just connecting and being us. I'm also a member of the US People Living with HIV Caucus Steering Committee together with Malcolm, and it's a great opportunity and platform that has really shaped my thinking, education around US policy and programs and what needs to happen moving forward. So I'm very excited to be here and to share what I do with you all.
I love that. Y'all see we have a very dynamic panel of folks with amazing expertise and lived experience that I think is going to shape a really kind of dynamic conversation. I think we can kick it off with like the first question, which is really around the phrase and terminology of ending the HIV epidemic. How do you think that term, how do you think that phrase, ending the HIV epidemic, specifically impacts Black people who are living with HIV? Is that phrase stigmatizing? Does it perpetuate harm against Black people living with HIV? What does this terminology, if anything, you think do, particularly for folks who are living with HIV?
So I guess I'll start off the conversation around this particular question, ending the HIV epidemic. This particular phrase has always kind of bothered me a little bit because I think I can't speak for others, but I like to think from being in community with others and what I have heard that I think that the terminology is concerning because when you hear ending the HIV epidemic, I think it lands on people's ears as we're ending HIV. And that's not necessarily what's happening, right? And so when we talk about is it perpetuating harm or stigma against Black individuals living with HIV, I just think in general, there's still a lot of dismantling of stigma, misinformation, and things like that. So when I hear ending the HIV epidemic, I'm like, okay, if we're ending an epidemic, have we talked to people about what an epidemic is and what's next after ending the epidemic, right? And so I just think that when we're talking about terminology, I think that there can be some reframing that can be done with the terminology. So that's how I'm going to kick it off from my side.
Yeah, and I second all of that, Kayla. And I also want to say that if you say ending the epidemic, but you don't use the word cure, then it becomes problematic, right? Because when I first got into this work, I did had a couple of meetings with people in the Reunion Project. And at that time, we were discussing using the word AIDS and people first language and living with HIV. And a lot of folks who had been diagnosed with HIV back in the 80s were attached to the word AIDS and did not want it to go away because they said that it belittled the battle that they had been through. And so when you think about ending the HIV epidemic and ending HIV, it's okay, you're going to end HIV, but what about those of us who are living with HIV, have lived with HIV, and will continue to live with HIV because you have not used the word cure? So what are we supposed to think about that? And I as a person living with HIV since 1996, I look back and I say, well, wait a minute, we want to end the epidemic. Yeah, that's fine. But what happens to those of us who are still here? And as we see things moving more and more towards prevention, and forgetting that that care is prevention, that we have to make sure that people stay in care. So because we talk about U equals U, but then we immediately go to PrEP. Well, let's be clear. As a person living with HIV, I need to be able to access my medication. I need to be able to afford my medication. I need to be able to do all of those things so that I am helping the community prevent HIV. So we have to make sure that ending the epidemic has the word cure in it. And if it doesn't, we have to make sure that ending the epidemic lends itself to supporting those of us who are still living with HIV.
And Malcolm, you just mentioned what I was thinking when I heard that term. I didn't put myself in that bracket because, as a person living with HIV, then it was a program that did not center me as a Black woman living with HIV. And so at some point, I was not interested, actually, until we got funding in my organization. That's when I started getting interested and starting to know, oh, what does EHE stand for? But in one of a committee that I served in back in Africa, we had recommended the term beyond zero. And I think I like that, something similar. I don't think even ending new infection is the correct way. I don't understand all aspects of English, which we'll talk about it later. But when I think about beyond zero, Kamaria in the video did mention that it is much more than stopping new infection. It is much more than having everyone on medication, having everyone maintain viral suppression. It is beyond like having quality of life for people living with HIV. And I wouldn't know the correct terminology, but it is the bigger picture actually that involves us, people living with HIV, much more.
Hearing our panelists and just overall the topic at hand, I think it's really on the perspective of how you view it, right? Ending the HIV epidemic, right? It all depends on what landscape. As a person with HIV, I think the terminology is great, right? Because to me, it lessens the stigma. But there's so much nuances to it, right? As a person living with HIV, and this is and doing consulting work and making sure that people are educated, making sure that people are accessing medication, all the work that I do and its complexities, that we're leading towards that goal. But we cannot forget about the people living with HIV and those that's working in this service that, okay, would I have a job after this? Would I have housing? Would I have certain things that is part of my livelihood, part of my regimen that keeps me afloat, right? And so when we having these conversations, I think that there needs to be some of the fine prints really spelled out so that we know that we're all getting towards a goal, that we're here to end the stigmatization, and that we're here to also not end somebody's livelihood. Because I'm telling you right now, again, I'm very unethical with some of my responses. I'm not taking no cure if it means I'm going to lose my housing. That is not going to happen. I'm like, my housing is part of my mental stability. And so we really need to be very clear and what are the policies that are going to follow with the HIV and AIDS epidemic, that it's not going to lead. We're going to take care of this problem, but then there'll be a slew of other problems following that. And that is no way that we want to end this HIV epidemic.
Wow, we knew y'all would be powerful. You're already starting off. And y'all already touched on so many key points. I'm hearing quality of life prioritization needs to happen. I'm hearing so many things, like how we talk about you because you and then immediately jump to PrEP. I'm just curious on what are the key issues and barriers to access, specifically experienced by Black people living with HIV.
So when you talk about access, you talk about affordability. Um, and, you know, I tell people this all the time, you know, I remember years ago, somebody said, well, everybody's got access to a good education. Everybody's got access to this, you know, from the other side of the aisle. And I tell people this all the time. I lived in New York. I grew up in New York. I walked down Fifth Avenue. I had access to Tiffany's. I could go into Tiffany's. And that was about it, right? I can't buy anything in Tiffany's. I can't afford anything. So when you talk about access, let's talk about what can we do with that? And, you know, even now, the paradigm is, okay, we're going to provide access to, you know, with Ryan White and to some extent with EHE. EHE has taken a little of the financial burden off of people, but we still have this notion that people that are working a full-time job making a certain amount of money don't need assistance. You know, my Dovato costs $3,000 a month. Okay. So if you take the people who are working every day and you say, okay, we need you to, you know, we want to provide access, understand what that means, that you have to help them because nobody can afford $3,000 a month in cost. So that's an issue. Not just about it's about being able to get to the doctor, being able to go to the doctor, but it's also being able to afford that care. And when we say affordable health care, even, you know, I just started Medicare, and what a shock. You know, with HIV drugs being Schedule 5, a Tier 5 drug, and what that's cost. And I know that in the next couple of years that's supposed to change, but right now, if it wasn't for private funding or you know, other things that Avita Care has told me, hey, this is available to you, this is available to you, you know, I would be in a lot of trouble right now. And I know that there are people out there that just don't have that information. So, you know, I think one of the things that we can do is try to make sure that pot gets bigger, because it's not just about, and it is about, you know, people who are below a certain percentage of the poverty level, but there's a whole lot of folks out there that are working every day that have quote unquote good jobs, but they're still looking around going, wait a minute, how am I going to afford this? So I think we have to talk about that. When I was working for AT&T, I had great insurance, but I knew that the first 3 months out of the year, according to my insurance plan, I was going to have to come out of pocket full cost for my drugs because my deductible was $7,500. And I didn't know about copay cards at the time because I didn't have anybody to tell me about that. I didn't know about that until I started working in this field. So those are I think those are some of the issues that a lot of people don't think about.
Allow me to talk about please, Mike, about the African Black immigrants who are here in the US and focus on that for a minute and the barriers that we face or experience when trying to access either prevention or care services. You know, when you start talking about language barriers in itself is a huge issues. One of the things that I've noted, for example, for us Africans, we have thousands and thousands of languages. However, even the major languages, for example, Swahili, the one I speak, it is not easy sometimes to get interpretation for those services when accessing healthcare. And that is a huge barrier. You want to explain to someone medical terms in English that they cannot read and understand. That is so difficult. I just want to share an issue. I didn't realize, I'm an interpreter myself, but I didn't realize the challenges of phone interpreter and how people are feeling that they don't want to access services, especially if there's someone on the phone interpreting for them, because this is someone they don't know. And just to mention, we are very few, so it might be my neighbor, someone who knows me from the village, and they'll go home saying the way I'm HIV infected. So that was one thing that really put me off, and I felt we need to do better in terms of language justice. In issues of insurance and immigration, that's that story for another session maybe we need to have. But just navigating the complicated health system here in itself is overwhelming. It took me over 7 years just to understand what is a copy, out of pocket, you know, like in network, all those things I didn't understand. And by the time I understood them, I had medical bills that had gone to collection. So really, all those things really affect how we access health services and information and even resources sometimes as immigrants.
I would add a little bit as far as like when we talk about access, access could be a blessing and a curse depending on where you live in the United States. As me living in New York City, I would say that there is plenty of access. I'm very fortunate to have services that are very accessible to me, but the service providers or the people working there are not the greatest people at times. And I tell people, healthcare is a business at the end of the day. And so I said, I'm bougie by nature. I have a bougie disease living in me. So I want the best possible experience when I walk into your space. And I've had plenty of friends, family members that walked into some service providers that they had access to, but the people working there or the language or things happening there had really turned them off. And so they didn't want to access that place or access or being engaged in their care based on the people that work there. So when we're talking about access, you know, we have to look at the landscape all across the board. Those that are working in service providing, people who are HIV, who are the first interactions that people are accessing when engaging in some type of care or even talking around HIV. I've definitely walked out of several service providers, social. I've walked out of plenty of offices because I said, you're not going to talk to me that way. You're not going to address me that way. We're not going to do that today. But it took for me to become an educated consumer is when I became a powerful provider. And so we really need to talk about how access can definitely be a blessing and a curse. Well, not a curse, or, you know, that's how I frame it, a blessing and a curse at the same time, depending on where you live in the United States.
Okay, and to piggyback off of Ja as well, I was just going to say that for one, first and foremost, when we talk about access, it is a very layered question because access does look different for everybody. Starting off, we have Black skin. We're talking about people who have brown skin, Black skin, people of color. We're talking about already off rip, we have a barrier that's systemically on us, systemically already in comparison to our white counterparts, meaning the wage gap, the education gap, the resource gap, you know, that layer already exists within minority communities as default barriers. Once we acknowledge that systemic barrier and how social determinants of health, which are the non-medical barriers that we face, influence our access, then we can actually dig into things like access around existing resources and programmatic structures. And like Ja was just saying, provider client care, like how providers are treating us and how they're talking to us, and why we have accessibility, but nobody is actually accessing the resources because they don't feel comfortable, or the providers are not informed. They're not trauma informed. There is no language justice in that framework. They're not sensitive to our unique experiences. So I want to say that. Now, also, there are resources and programs available. However, those are often demographically and geographically specific, meaning if you have the qualifications in terms of needs but don't fit the bill of eligibility to a T, then you don't receive those resources. So the access is there, but then you're not eligible. Or you do fit the bill, and then you're faced with other barriers such as location of services, provider client mistrust, or discrimination. So it gets deep when we talk about access. Like, imagine having a full running clinic, right? Ryan White, you offer insurance, they're covered by whatever insurance program, whatever state you're in, and you have everything that client needs. They come in here, they're ready for the services, they're open to receiving care. And because they're a woman and they're pregnant, they have everything else to check off the boxes, but she's pregnant. So now she can't receive services, and there's nowhere else in the city for her to go because she doesn't have insurance. No one else will take her. So when we talk about that's just on a small scale, but when we talk about like key issues to barriers and access, it is very layered. It is not just a one size fits all. And that's why we get together and have these conversations, so we can kind of get a glimpse into everybody's background and what it looks like for everybody.
Yeah, I think that's great. I mean, I think that so much of what y'all are talking about is like there's access, but really it's about the utilization and about like how do you can put your foot in the door, you can find the clinician, there's organizations, there's places to go to, but it really is everything else that impacts the ability to utilize what we say are these, life-saving medications. And so whether it is utilization challenges when you get into clinic, right, with insurance and the various kind of healthcare plans, but also, Jai, you talked earlier about like housing, and there's all these other things that allow for people to live full and healthy lives that have to come first if we really want utilization to happen. And so I feel like when we talk about Black folks and HIV, we can talk about access, but hand in hand, right after, really access doesn't mean anything if there's not utilization there, and there's not opportunities to really support that. I'm interested in, you all reflecting a bit. So we are four years into the implementation of the Ending the HIV Epidemic Initiative. And how do you think the quality of HIV care has evolved? And what are some of those tangible improvements or setbacks, depending on your opinion, that have been observed when it comes to the quality of HIV care underneath EHE?
Okay.
Go ahead.
So I know I'm looking at everybody's faces like, how has it improved? Because we here having this conversation right now for a reason, But what I will say is I think that we have come a long way. I know, like, when we're in the midst, we're around, we're seeing everything that's happening, it's easy to be like, well, there's still so much work to be done, but the EHE initiative has allowed a lot of programming, funding for a lot of different organizations for us to be able to hold these spaces. So very grateful for where we've come. But when we talk about getting into the specifics and the details, there are a lot of nicks and kinks that still have to be worked out. And when you talk about an initiative, like, I could see if this was like the third or the fourth initiative rolled out, but when you're first starting a program, you might not get it right the first time around, So I think in terms of PrEP access. I mean, I remember when PrEP first came out, it was like, oh, that's nice, but I can't go to my local health department or clinic to get PrEP. And so now when I'm looking around, we have more PrEP accessibility. Like people are getting on PrEP. So that's major. When we're talking about retention and care, like in some rural areas, there are still gaps there, but we're seeing more people be on medication and attaining viral suppression. So we have definitely evolved. We see people now, people are not having to take cocktails and 3 and 4 or 5 pills. We see people now being able to take 1 pill. So we've seen advancement and we've seen the visibility and accessibility for those resources. We've seen that happen. Now we could talk about setbacks all day. I don't really have much to offer on that right now for this. I want to kind of highlight the good things that have come about, but from my experience, even being able to be in a clinical setting and see it has evolved a lot from as a person living with lived experience and seeing where I came in at and how it looked for me and how it has evolved and advanced. I said I wasn't gonna say it, but if I could say a setback, I think the only thing I would say is that while we've given resources and we've kind of pushed, the initiative has pushed for these resources to be there and for clinicians to, you know, make these available in their clinics. I think the biggest thing that one of the biggest things that I've seen is provider client experience. Like you're giving these providers all this stuff to implement into their program, but you're not equipping them with the proper like terminology. They're not as compassionate. They're not understanding that these people with lived experience are not just a number. And so I think in conjunction with the resources you are providing, also some training, a lot more training could also be in conjunction maybe with that. So that's my piece.
Yeah. So yeah, you said training, culturally competent, you know, doctors, providers who understand people from different backgrounds. That is key. Also, you know, I was hoping that it will also result in hiring more people who look like us and would see them in these facilities. I'm yet to see that. But on the other hand, I really do see some improvement when we engage in community engagement sessions. We talk to people about stigma reduction, provide services, you know, to people who look like us and speak like us. That's a huge, you know, kind of improvement for me from EHE. And most importantly, funding community-based organization who would normally not get such kind of funding from other funding stream. That is something I see in our jurisdiction. For example, we are working with African immigrants population here in King County, and I've seen the number of people we've been able to reach, people would not be able to get to. However, the other setback for me is the, you know, like this, the life of the funding cycle. For example, we cannot have solution based on 1 year, 2 years, 3 years funding cycle. Our population, our communities, whether immigrants, whether Black, African American, we really have to invest in relationship building, you know, and work through those communities to be able to provide services that will be utilized. And so a program that will invest in relationship building first before providing services would, to me, be a better option, well-funded and multi-year funding for such community-based organizations.
I'm gonna say there has been improvement that have been said on this live panel, but the setbacks are definitely there. I mean, it's very unfortunate that my livelihood is based on who's in that Oval Office, right? We had an administration that shut down the efforts that we've done, right? For 4 years, right? And so now we had another administration have come up and say that, okay, the work that we're all doing is very impactful. That impacts us, people's lives. And I don't know about you all, but I'm getting tired that my life is based off somebody in the office. That doesn't work for me. And it impacts my mental health. So while things are being progressive, I think about underserved communities. I mean, like, we should have definitely had a person with trans experience on this panel to talk about how the complexities of being a person with trans experience, being HIV positive, how navigating the healthcare system. We have individuals in the prison systems that don't have access. We have our hard of hearing and deaf community. We have so many underserved communities that are still being impacted, even with the access that we can have or how people we navigate. And so it's really important that we realize that our lives are impacted by so many institutions, and the work that we do can be so great, and we could talk about it. But when I can see that's going to be an issue in a few months, really it bothers me. And so I'm here to celebrate our progress, but also talk about, like, there is a lot building up that I don't know if we have the resources or tools to really fight that. I'm very optimistic, but yeah.
Malcolm, you have some words to.
Yeah, so I definitely agree about the funding screen and the political impacts, and even beyond the Oval Office. I mean, I'm talking about a certain party in the House of Representatives who wants to just cut everything, right? And it's but that's where we have to educate. So, I mean, the question is about, have we made any improvements? I'm a man of a certain age. I watched people die in the 80s. Yes, we've made improvements. We've made significant improvements. One of my friends who passed away in the 90s, I remember him taking 19 pills. Some of them had to be refrigerated, some of them didn't. They all made him sick. And so I watched that. I lived through that. I praise God. I'm fortunate that when I was first diagnosed, that I had a 3-pill regimen, and then it went to 1 pill, and now we have people that are taking a shot every other month. I believe Daniel is participating in the call. So yes, we've made huge strides, but as was said, equity of underserved communities. What is the Ending the Epidemic plan doing to try to get to all of them? And when you talk about 57 jurisdictions, what about the rest of this vast country that are not part of those 57 jurisdictions? I always question that. And then again, when you talk about the political aspects of it, and going back to the first question, I always remember who the Ending the Epidemic, where it came from. I always remember that it was Donald Trump who stood there on the State of the Union and said he was going to end the epidemic, and everybody was like, "Wait a minute." And when you take a gift from a con artist, always watch what's going on the other side of that gift. So I've always questioned that. Yes, we're doing what we can do with those funds, and making sure that the people in our communities are served to the best of our ability. But we do have to make sure that we keep in mind that there are a huge swath of people that do not have access to this funding and to these benefits. So yeah.
Malcolm, that's real. It sounds like, things have improved a lot. Injectable treatment is definitely out there, but do we talk enough about that it takes some folks 2 years to get on injectable treatment, right? And so I definitely hear the tension from the panel between the progresses that have been made, but also the remaining barriers that prevent us from truly fulfilling access and utilization of these resources. I was very, very touched about something that Jah said earlier in our conversation, especially around trans representation and centering, sort of like how, the EHE impacts trans communities. Oftentimes I think of gender affirming care, right? When I'm thinking about our, transgender justice and gender justice, et cetera, I oftentimes call gender affirming care HIV care, because we know that Those of us who are of trans experience and also living with HIV are who have access to gender affirming care are more likely to be virally suppressed, right? And so it makes me think about all these gender affirming care bans that are happening on the state level, and how that could potentially impact our ability to be virally suppressed. So on that note, intersectionality remains a critical lens in understanding the complexities faced by Black people living with HIV. How effectively does the Ending the HIV Epidemic initiative address intersecting issues such as gender justice, reproductive health, immigration, substance use, viral hepatitis, and youth-specific concerns?
Okay, I want to start. So all skin folk and kinfolk, and I just have to be very blatant out there. There are a lot of leaders, Black leaders, that do not do not respect the LGBTQ plus community, and so therefore, when they are advocating for Black people, they're excluding the LGBTQ plus community, and so then it's harder for me when I'm going in and then making sure that I have to dismantle what one person did to just say that no, we all are inclusive, right? And so when we talk about the liberation, we talk about Black people moving forward, we all have to have one note, like one band, one note, one band, you know what I mean? And so, to see it's very sad to me to see a lot of Black leaders in leadership position that do not advocate for all of us in its totality. And that's impacted us because then the right wing or whomever use that rhetoric to just, use against us as a whole. And so we have to be very mindful that how we advocate, who we're advocating for, and how we're pushing our own genders that impacts all of us. As a person, I say POC purposely, right? I make sure that as a cis Black gay man, I still talk about our trans community in every space that we go to, and I go to, so that people are just not forgetting. And so I say that to say that there is so much work, but there's so much healing that needs to happen amongst our full Black community to make sure that all voices are being heard and recognized, and that when you are hurting one of us, you're hurting all of us.
And if I can just jump in real quick, I think that goes back to investing in what Teresa earlier talked about building relationships just amongst us, putting our own house in order. We have a huge diversity that we need to address, and to see how we can support each other before we can ask people to support us. We can speak in one language. And I think that's just a part we need to really invest in, because it has come up a lot.
Yeah, I just want to add that, and in regards to the question of how effectively the EHE epidemic has, or the EHE initiative has kind of addressed intersectionality. I don't know if maybe I'm blind, but the visibility is not there to me. I don't see it. It's kind of like a melting pot. Like, you get some money, gonna give you some money. Y'all fight for that money over there. Y'all fight for that money over there, and everybody is in their own like segues. And when we come into these spaces, we create intersectionality. We've done the work to create intersectionality, but EHE, the initiative itself, I haven't necessarily seen that. I see division in terms of I've seen youth specific concerns on there. And I just want to touch on that again and say that the inclusivity of youth in that scope, in that realm, is just kind of weird to me, because we can identify what we consider youth. They say 13 through 24, I believe the age is. But we can't get in schools, but we cannot get in schools, and the legislation makes it that way. But then y'all put on a government website that this population is most impacted, but there's still not a lot being done in terms of legislation to disseminate the proper, up-to-date, accurate, medically accurate, inclusive language. We still behind the ball on that. And so when we come into these spaces, I'm 25, so I'm still considered youth, but I'm like, I've been talking about this for a few years, and it's just really hard to get the ball moving on that scope. But anyways, I just wanted to touch on that because I'm considered a youth in the space. So I always want to kind of uplift the challenges or the concerns that I have around what's going on in that scope. But even then, being a youth and trying to intersect into segues, there are not a lot of youth in these spaces speaking up because, people don't necessarily, I don't want to say people don't care, but that's kind of how it rings sometimes. The young people, we're the next generation, new leaders and stuff like that. And I think being given this space, I can say that the opportunity space has been open to me and maybe some others. But anywho, there could always be more intersectionality. I think they could do better on that. So I'm gonna just get off my soapbox.
Yeah, and intersecting identities related to immigration is something like different for us as immigrants, Black immigrants. There are these negative immigration policies that really affect us and affect how we utilize services, even employment, and can even dictate whether we are going to go for test or we are going to go for a treatment or adhere to medication based on our immigration status. So these policies, for example, immigration policies, they promote fear in institutions. You saw during the last administration how hard it was for immigrants, all immigrants, brown and Black especially. They reinforce that discrimination that people feel when sometimes they come here based on their color, based on their language, and how they speak English. But most importantly, they deter us from utilizing the services that are available. I know 3 people who were sending for medication from their countries back home until the border agencies intersected and they could not receive the medication. And one person just stayed and couldn't access services for almost 1 year because of fear that when they come out, they might be deported back to their countries. So we can never emphasize on the need for such a program, also looking broadly beyond just access of prevention, PrEP, and medication, to look at other services that might be affecting how people are uptaking HIV prevention and care services. So the other thing is that all of us as a community of HIV community, whether we are people living with HIV, working in the HIV field, we really need to bring immigrant population on the table when we access such forums where we are talking about barriers to care and treatment. Someone said we have to be a brother's keeper, our sister's keeper. And because most of the time it is really difficult for me sometimes to find myself in such a table. But if you find yourself there discussing about issues for Black people or immigrants in general, it is important to bring issues of immigration to the forefront.
Yeah, I think that these are the concept, the approach of intersectionality is so important because we live such layered lives. And I think EHE, Malcolm, I'm with you. We all remember when this announcement dropped. And, when we read what the initiative was going to be, we learned about it. One of the things that I always point to, the thing that I was like, okay, the money is good, and the request for innovation is good, but innovation is such a broad term. And I think that really the kind of innovation that was needed is how we have an intersectional approach to our response to HIV that is really specific to Black communities. And I think without it being structured at the EHE level, right? Intersectionality, if you think about like the 4 different pillars that you have, it's like prevention, treatment, diagnose, and then response, which is really about cluster detection, molecular HIV surveillance, which I know we can have a whole nother panel of a conversation about with this group, especially when it comes to Black bodies. But you know, where's the innovation and where's the intersectionality in that approach? And Kayla, you talked about that, like we be just talking to each other. And we, as implementers of it, I think have intersectionality in mind because this is our communities. We know who we are, and we can try and be responsive, but we don't have resources that are directed at that kind of intersectional approach in the same type of way. And it really has to come from the top. So I think this question around intersectionality is, you know, so important. You know, I think the other thing for me that when I think about HIV and HIV specifically in Black communities, you know, we've had all of these advancements from a biomedical perspective. Malcolm, you talked about like, you know, are things better? Yeah, right. Overall, when it comes to HIV, it's not the 80s, it's not the 90s. We have these amazing biomedical tools, but I feel like there's some things like stigma that are so big that we know are so impactful, but it feels like the boogeyman. How do you define it? What is the changes that have happened around it, right? And why haven't we seen advancements in things that we know are impactful, that impact like access and utilization and things that we were talking about before, like stigma? And so, you know, stigma, I think, is a big catchphrase, right? That's really about how people and how value is assigned to certain characteristics of identity compared to others. And we know that HIV is deeply stigmatizing and is a part of the reason why people don't put their first foot in the door when it comes to clinics, when they aren't talking through and sharing their status with others, and when it comes to thinking about PrEP and who should be a good candidate for PrEP. But I'm interested from you all, from this group, you know, considering kind of our large goals of ending the HIV epidemic and this initiative by 2030, to what extent has stigma surrounding HIV been mitigated? And what are some of the ongoing challenges that we continue to experience when it comes to mitigating stigma? But first, you know, answer, has EHE done anything you think to advance stigma when it comes to HIV?
I think so. And I say that with a question in mind. I don't know if all of these commercials about, you know, the HIV drugs, I don't know if all of that funding is coming from EHE or if it was um, um, brought to fruition because of EHE. But, you know, as you see people on TV talking about U equals U, and, you know, you see not only gay folks on TV talking about their HIV status, but you see commercials with married folks and everything else. And I think that that is doing a little bit to break some stigma. I think where we are as far as stigma, or what we have to do as far as stigma is bring the rest of the community outside the LGBTQ community, outside the people living with HIV community. We have to bring those people in. There are so many people that I speak to that mom and pop Joe that don't know anything about HIV. And because they don't know anything, they still have this fear. And I don't know that we are doing enough to involve them. I think it was Kayla who said we tend to talk to each other. And you know, I was talking to this young man, I believe it was at USCHA, and they had a program to go into the barbershops in the neighborhood and talk to, you know, a lot of these guys about, hey, this is what's going on. And I'm not talking about a barbershop in the neighborhood, right? I'm talking about a barbershop in the hood, you know. And you know, those are some programs that you know, I think would probably help more if people understood um, the concept of U equals U. If people understood all the things that people are going through living with HIV, I think perhaps that would change some things. But I think right now we still tend to talk to each other. We talk, we talk to the LGBTQ community, we talk to the HIV industrial complex, if you will. But we have to get out there and talk to people. Whenever my sisters get mad at me, right? Because when we're at a family gathering, I'm going to bring up HIV. You don't have to talk about it all the time. Yeah, I kind of do. Because your friends don't know anything about this. And they might have somebody in their family that is afraid to say that they're living with HIV because the family is stigmatizing them. So, just making sure that we're having that conversation on a general basis. Thrive did a photo campaign years. Well, we still do it. It's called our I Thrive photo campaign. And I remember when I released that first photo on social media, and I remember how scared I was. I sat by the computer and I was like, push the button, don't push the button. And when I sent that picture out and said, hey, I'm a person living with HIV and blah, 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 the response was overwhelmingly positive. Not because I have a whole lot of gay folks on my timeline, but even folks that I went to school with, even that I went to school with years ago. Hey, Malcolm, this is great. Hope you're doing well. Blah blah. And so I think that a lot of us are afraid to talk outside of our circle, and I think we have to get over that.
I must say I agree. As a person that's done several HIV campaigns and I post them on my social media platform, I get huge response from the LGBTQ plus community, from my straight friends. But I've when it comes to the EHE and ending the HIV epidemic, I really like to, and I do talk to medical providers and people that work in this social service providers, because I think they're the one that's it's a vague statement I'm about to say, continue the ignorance and stigma around HIV, especially a lot of medical providers, because of their complicit biases, or how they were taught through medical school how to treat the disease and not the person. And we know that when treating HIV, you have to treat the whole person. And so I've always say that we need to educate the medical students. We need to continuously having education and trainings, because the language that providers use could be very stigmatizing. And then depending on what person they're servicing, that person can internalize it, and then it just goes out into the world. And so us advocates are doing the best that we can in ending a lot of the stigma. But if we are going to be combated by those that people look at, they're the professional, so they know what they're talking about, and we're not addressing them and telling that they're the way that they're providing service is harmful, and the language that they're using, then it becomes very counterproductive to the work that we're doing as a person, as a person with HIV, and showing people that I've been living 20 some odd years, and people are just like, oh, that's just Ja, because Ja's doing it, then it doesn't really reflect the whole community. And so we really need to utilize our dollars, or make sure that we're continuously talking to our service providers on how they're talking about HIV and treating people with HIV, because that is where I think a lot of the stigma is definitely coming from.
Also, in addition to creating awareness, I think there is need to center Black people living with HIV, including foreign-born Black population, into campaigns and those advertisement and TV programs. That would be really good, so that we can relate to the people who are talking about stigma reductions in the community. Also, there is need to increase and support Black-led safe spaces, because that is what that has made us to who we are as people living with HIV. And I don't think we are talking enough, or praising, or sending flowers enough to the people who came before us. The people we remembered today who did this work. Many more are with us, and others left us. We really need to be talking about them and the work that they've accomplished, but also being able to create that space for someone else, to be there, to experience what we are experiencing. So as Jahlove, you said, who is being left behind? who is not here with us? How can we bring them on board? Because the stronger that we are together, then it becomes easier for us to face these challenges from outside the community. We face deeper stigma from cultural perspectives and values from our community. And just learning how to deal with that, with people who love you, who they say they love you, they care about you, but they can't stand being with you because you're living with HIV is horrible. So how can we reach to such communities? How can we work with community gatekeepers, religious leaders, who are, gatekeepers in our conversations and HIV response? I think we still have to do more on that.
Come through with the truth. And thank y'all for this. As we start to wrap up our conversation today, first of all, I want to say this chat has been fired throughout their entire conversation. Like, I feel like everybody who's part of this experience is part of the panel, because I've been getting information from the chat, from you all. Daniel Jiffin is just keep dropping on this knowledge in the chat. Tyler was writing dissertations in the chat that I was like trying to copy and paste into my notes. And I kind of want to be missing, be like, what jurisdictions, Daniel, are doing disruptive innovation better than others? I'm just curious, but I'm gonna stop. I'm not gonna be messy. The last question I have.
I got a little time.
You got time? You got time?
Because I want to know too.
So I think you guys lifted it up. I think so often we have an all or none approach in many of our conversations. I think we have to truly realize how diverse each state, each jurisdiction is, and take the time to dive deeper. So there's an amazing qualitative report that HRSA had put out specifically connected to EHE, and it highlights some of these disruptive projects that really brought more than 9,000 people who had never been in care back in care during the 3 years of COVID. So, again, like we have to, do we have everything figured out? No. But again, like in certain pockets, in key pockets, we are doing some powerful things to keep people in care and get people to become virally suppressed. That's never been before. So that's all. That's all. I'm gonna go back on mute. I'm gonna turn my camera off and mind my business. Okay.
All right, then I'm gonna wait for that link to be dropped in the chat of that HRSA example.
And it will be interesting to see how much of those folks are Black folks. Who are those people they're able to bring in? Daniel, maybe you want to come back and if you know. But I think that is one of the areas, and I'm sure you do know. Go ahead, tell us.
I mean, so again, we have to realize that 75.9% of the Ryan White program are people of color.
Yes.
Okay. So if we are just mindful that this program as like an equity initiative is bringing that many people to baseline, I think more times than not, they'll follow suit. When we think about viral suppression, especially across this nation, when we started this conversation in 2010, viral suppression was 69.3%. Okay. Today, across Ryan White programs, viral suppression is 90.1%.
Yeah.
Okay. So like, and finally, like the racial disparity. So like the gap between the different lines that you see on charts, that gap is shrinking. So that means disparity is being reduced, So again, like it's finally working. Can it work better? Yes. Could it work faster? Of course, but we are making progress. And I think we have to, continue to lift that progress up.
Yeah.
That's
I think
it.
the Ryan White. You're not done, but it's okay because it's family. So you can act like you have, you put your jacket on to leave, but we know what's really happening. And I think that the Ryan White program is a good example that even before EHE, we saw a lot of success in, and with more resources, we're seeing do better. But Ryan White is explicitly for people who are living with the HIV, and it is the payer of last resort. And so Ja, you talking about this is a bougie disease, it's a short stop, right? It's kind of like a gap solution. And I think that one of the reasons we're not talking about PrEP, but we will at some point in more detail, it's one of the reasons we don't have the same type of impact, and we actually see widening disparities when it comes to some of our prevention efforts.
And the doctor dropped the link in the chat, y'all. Thank you so much. We do have a final question for the panel, and thank y'all for your patience with that slight diversion. But we had to bring the doctor into this conversation. But I actually do think it bridges nicely with the last question, which is considering the goal of ending the HIV epidemic among every Black body by 2030, do you believe this is still achievable? And folks, if you want to drop your thoughts in the chat too, I live. Come on.
I can go first. I think we still have a long way. It's hard to even imagine 2030 is not far off. We are yet to see where we get with this initiative. However, we have seen that there are some strides, but we also have a lot of work that is remaining. And as we said, unless we address the underlying issues that have been mentioned here, we still have a lot of work to do. So there's need for me to invest in the community that is most impacted, deliberately invest in those community, and to champion the work of Black-led folks living with HIV. There's also the need to have people living with HIV lead, not only in community engagement, a few speaking roles, being invited in some advisory committee, but real policy work, and even designing programs and funding mechanism, having decisions around that. So someone mentioned who is making those decisions, who is representing us in funding decisions that are being held every day. Are there people living with HIV, Black people living with HIV there? So it will be important for us to know that and see how we can influence those agendas as Black people, especially as Black people living with HIV.
I think it's definitely possible. What I definitely like to see is that more diverse leadership, right? More unethical leadership. There are plenty of people that we always talk about the population that are not getting tested, or how can we reach those population. There are plenty of people within that are leaders that we don't feel are leaders because they're unconventional, right? There could be a porn star, there could be a ballroom walker, there could be a pageant, there could be a drag queen, there could be all these things. But each person that has a platform have people that look up to them, and that if we equip those leaders with the terminology and education from what they already know, we can definitely end this epidemic. But we have to add more people to the plate, and more people that we don't see. Right, I'm one of those persons people didn't see, but I'm very impactful in plenty of ways.
I think what goes on in that building in DC, as far as funding is concerned, is huge. I think if we allow Black folks to think that we need to go in another direction as far as where we cast our vote, and those people stay in power. And Daniel pointed out something in the chat a while back, that it was Republicans that came up with all of these initiatives, and the epidemic, PEPFAR, all of that, but now they're trying to cut it. And hopefully cooler heads will prevail. I think the Biden administration should have requested an increase, but I think they knew what they were dealing with. But we can't let them cut. We can't let them cut. And if they do cut, then where are we as Black folks? What can we do to make sure that our people stay in care? And that's a tall task, because that is a financial task, right? So I think that's the question. How can we make sure that that funding stream does not go away, or does not even get reduced? So Exactly, Daniel. Right.
And Tyler, child, you see I can't take. Anyways, I'm sorry. I don't want to interrupt. Y'all continue. Kayla, you have final thoughts? I know you do.
I didn't even see Tyler. So, oh my goodness. Yeah, exactly.
Yeah, so I would say I think the goals are very ambitious. Do I believe that is still achievable? I'm not gonna say what is or not is not achievable. Like I said, I think it's ambitious. I also think that the terminology for me, it's the terminology for me. I think also equipping people with understanding what's next after ending the epidemic is what my biggest thing is. Like we've talked about earlier in the conversation. What happens after we end this epidemic, I feel like is a very important conversation to be had. So yeah, I just think more conversations have to be had around what that looks like. I know the goal I think y'all said was to reduce HIV transmissions by what, 90%? That's the goal. I think we've come a long way. We made some major strides. I don't know collectively how that looks. Maybe like regionally, you can kind of see if that's achievable, but I don't know how that looks for us as a whole. So I don't know if that's achievable. But I just think we have to continue to take up space, have these conversations, show up, connect, network, and just do the best we can by talking and speaking up, using our voices.
That was a very, very powerful point, especially around, the how we're unclear about the collective reality of us being able to achieve these goals, but how certain communities might be able to do that. You know what I mean? I think that touches on the layers that we've been dissecting throughout this entire discussion. Ms. Copeland, would you like to close us out? You just do such a beautiful job with.
Thank you guys so much for being here. Thank you to the folks in the space, in the virtual couch that was cutting up in the chat. I feel like, that's dissertations that we're getting over there. We got some qualified and very smart and brilliant people. And so thank you guys for showing up and sharing that space. And then thank you to our group of panelists. I think, being able to have a group of folks, Black people who are living with HIV, who are thriving, who are advocating, who are doing the work every day, I think is, it's a beautiful thing. It's what we need more of. And for me, it has, it's been a bit of a healing after, for me, like kind of what this week has brought. And so, we're family and we're doing it together. And I'm so grateful to be able to do this work alongside y'all. We have the final installation of the series next week. Please join us for one more cut up together, one more time on the couch. Not Dazon in here too. I'm telling y'all, look in the chat. Oh, I need all the hugs and the feels. But thank you guys so much for being here. Thank you so much to United We Rise for creating this space for us to come together. We don't have enough of it. And so that leadership is critically important. And so happy. Please, you guys, join us next week for kind of our final series. Let's show up, show out. Thank you guys again. We'll see you soon.